Hi everyone, I'm Graham Durcan from the Centre for Mental Health, and what I'm doing today is celebrating with you an anniversary. It's the 10th anniversary of the publication of this report. So in April 2009, sorry, I go back to the cover, Lord Keith Bradley published the outcome of what had been 12 months of investigation, 82 recommendations, which recommended that we have an all systems liaison and diversion service for people with mental health problems and people with learning disabilities who come into contact with criminal justice. So what I want to do is give a bit of a potted history as to how that came about, and it's a very potted history. So essentially we've known from time immemorial that regardless of us having had at one time large asylums, we've always had a lot of people in our prisons who've had mental health problems. In the 1990s, this started to come to the fore in terms of public attention and public policy. Lord David Ramsbottom, then the Her Majesty's Chief Inspector of Prisons, published a report, I think it was 1996, called Prisoner or Patient, and that was really the sort of culmination of his frustration at having visited lots of prisons and constantly finding complaints about the number of people with mental health problems, that they were out on the wings, they were in the prison sort of hospital units and in segregation departments, and it quite clearly a prison was not the right place to look after someone with mental illness. And of course some of them probably shouldn't have been there at all. The offences might have been relatively minor, and often people, he found, were remanded to prison. So there was a real concern back then. Within a year of that, the largest and most significant and most robust psychiatric morbidity study of the prison population, and probably the only one we've really had, was conducted. So that was done on behalf of the Office of National Statistics. It was published in 1998, Singleton et al., 1998, and that gave us some of the figures that we know a bit about now. So I'll just really quickly go through some of those figures. So from that we know that 90% of the prison population have a drug or alcohol addiction, a personality disorder, or a mental illness. We also know that 70% will have at least two of those problems. And just looking at severe mental illness, I mean, that can range from sort of 5% to sort of 10% in the male prison population, depending on the type of environment. So with newly sentenced prisoners and in remand prisons, people tend to be rawer, sooner off the street at their worst state. So those will tend to have higher rates, and they're very pressured and stressed environments. So it's very widespread. I started to develop an interest in this probably around 2000. I used to work part-time in a prison, but the then Sainsbury Centre for Mental Health set up a prison program around 2004 to 2005. I was involved in that from the outset, and we learnt very quickly that actually, yes, it's interesting to focus on prisons, and at the time there was a growth in mental health teams, what we call mental health in-reach teams, going out to prisons. So these were teams at the time that were largely modelled on secondary care mental health teams, community mental health care teams. Now they have a much broader function very often, and they'll encompass some of the primary mental health care, because prisoners tend to have quite complex needs, and just a GP alone is often not enough. You need a more intensive approach. But anyway, we became aware back then that looking at prisons was fine, but an awful lot of people shouldn't get through to prisons, and that you needed to think about diverting people from prison where that's appropriate and where that's possible. You've got to think about public safety and so on and so forth. But if someone can't be diverted to a community resource, there are hospitals they can be diverted into, and secure hospitals. So we started recognising we expanded our programme into a mental health and criminal justice programme. Liaison and diversion services, as diversion teams get called now, are not new. They've been around since the late 80s at the very latest, and I think back then the Home Office and Department of Health put some funds in to prime the start off from some services. So they were largely in courts, some went into police stations. They pretty much were focused around adults. And at their heights, probably 5-6 years later, mid-90s, there was around 200 teams in England and Wales. They were never a policy must do, and I think some of those teams dwindled. There was also never a template for them, so they looked very different. There were a minority that were kind of all singing and dancing and very proactive and going in and actively looking to screen people for mental illness, because that's what they were largely focused on. But there were also ones that were referral only, run by voluntary sector services on very limited funds. And probably even where they were active, say in a court that they were active, that most of the magistrates wouldn't have been aware that they had this service that they could use. So not satisfactory. So in 2007, I believe it was, the then Secretary of State for Justice, Jack Straw, commissioned Lord Keith Bradley, a former MP, a former minister, and now a Labour peer, so in the upper house, to conduct what was going to be a 6-month review of the need for diversion and mental health and criminal justice. Lord Bradley decided quite early on that 6 months wasn't going to be enough. He wanted to do a much more extensive review, so it became a 12-month review, and that was what became this report. It's 82 recommendations, all stages. So perhaps let's have a look at what's happened since then. What have been the successes? And well, let's start off with some things that he was asking for that haven't quite happened yet. So I don't think we can call our diversion system an all stages system. I think there are still big parts of our criminal justice system that don't have access or immediate access to mental health or vulnerability provision. The biggest bit would be the probation service, so which we know we've got two parts. So we've got the National Probation Service that deal with high risk people, and we've got community rehabilitation teams that deal with the low to moderate risks. The National Probation Service will have a presence in courts, etc. But at any one time, they're managing, probably a couple of 100,000 people in the community, and many of whom, we've got limited evidence on this, but the best evidence we've got suggests around at least 40% have a history or an active mental health problem at the time. And that's probably an underestimate, and there'll be a lot of people with, if you talk about vulnerabilities more broadly, so autistic spectrum, learning disabilities, speech and language and communication difficulties, there'll be a much greater number of people in that population. The other sort of area that Lord Bradley had hoped liaison and diversion would be able to deal with was when people leave prison. And there are some schemes that do a little bit, but actually that isn't part of the national model. And that's an area that we need to deal with, because it's a really high risk time. If you're leaving prison anyway, you're not leaving with any money. It's going to be a while before you get any money, etc. We know an awful lot of people leave prison to not ideal accommodation. So there'll be some people who are homeless when they leave prison. So that there are some bits there to do. We also 5 years ago, at the 5th anniversary of the Bradley report, we produced this report. So Bradley 5 years on. There's a few things we asked for there. One of them was really a need to repeat the psychiatric morbidity study, but not just in prisons. It's very important to do it in prisons and to keep it up to date, but also in other criminal justice settings, so the probation population, and to do something snapshot and robust around the number of mental health incidents that police deal with, etc, etc. Okay, so there's a few things that haven't quite happened, but actually I think an awful lot has happened. So what has happened? In some ways, NHS England, who took over the reins from their inception, so from 2013, they actually wanted a specification. So myself and other people from our Centre for Mental Health and other organisations helped write that specification for liaison and diversion services. And what they wanted was a multiple vulnerability, so not just mental health, not just learning disability, but autism, acquired brain injury, any type of vulnerability. Now that wasn't particularly something that Lord Bradley had recommended, but has certainly supported. He wouldn't have been against that. He was focused around mental illness and learning disability. The other thing he hadn't made recommendations about was specifically around liaison and diversion for children. And the reason for that was there was another review around that time. So, he hoped that government would bring that together. And that's actually what's happened. So NHS England wanted not just a multiple vulnerability service, but an all-age service. And they set about from sort of 2014 onwards, launching pilots and different waves. And I think we've gone through about 4 waves of rolling out services, and there's probably a 5th wave and whatever to come. But where are we now? Well, about 80% of England is covered. So there are different arrangements in Wales, Scotland and Northern Ireland, and there isn't anything like the resource that's been put into this. So England, yes, it has the bulk of the population, but it's also the focus, obviously, of government agencies like NHS England. But a significant investment has been made in this, and we're hoping by 2020, certainly Lord Bradley is hoping by 2020, that we'll have 100% coverage of this, of England. And it would be great if similar models in Wales and Scotland and also in Northern Ireland, if we could see some sort of rollout there, that would be fantastic, and all of the UK covered. There are some other things that need to develop. My colleague Lorraine Khan, with the Youth Justice Board and Department of Health back in 2007, launched the first 6 pilots for children's liaison and diversion services. And I think they learned there that it's very important to work with young people coming through custody, but that's often quite a late stage. Children will very often have had a lot of brushes with the law to get to that point. And actually we want to try and prevent young people from becoming first-time entrants to the justice system, and early intervention, etc., needs to be a part of that model. That's probably the slowest. It's very complicated to do that. NHS England have a desire to do that. Myself and a colleague from Nottingham University, Eddie Kane, been doing some work in Manchester, in Greater Manchester, and we've made some recommendations there about how they might take up the opportunity to develop that upstream. So it's sort of variable and a bit hit and miss across the country, and that's the element that needs a lot more thinking about and a lot more development. But what we're celebrating on this 10th anniversary is actually a lot of success. It's taken a while to get here, but we're almost there. We're almost 100% of the way. There are some other bits that can be developed. There'll always be things that need to change, but actually I think it's been highly successful.